And I'm going to hand the floor over to a man who is extremely busy. His CV that I looked at is over 100 pages long. He's currently the surgeon at Liverpool Hospital. He is a professor of orthopaedic surgery at the University of New South Wales and the University of Sydney School of Public Health. He has a list. Seriously, the man is busy. He also has an Order of Australia. Massage therapists, please welcome Ian Harris.
Well, thank you for that very kind introduction. So I'm not going to be talking about massage therapy at all, but I am going to be talking about surgery, and I am told that this is something that you may be interested in. So I'm going to take you on a little bit of a journey, and it starts with a personal journey, because this is what got me into science in the first place. So I see myself as what people call a skeptic, and I need to clarify that, because when people say skeptic, they just think, oh, you just don't like things, or you're cynical. And there's a very important difference between being cynical and being skeptical. To be skeptical is to be scientific. So I see myself as a scientist. To be cynical is to judge the motives of people and not rely on the science. And what got me into science was maybe just sort of an innate interest or a hereditary interest. But I do remember one specific event which I'm going to talk about, and it relates to this here. So this is just something lifted off the internet recently, about water diviners finding water during a drought in Queensland. And it reminded me of how it all started for me. So I was at university doing medicine, and I'd only just started. I was in like first year, so I didn't know anything. And I was watching TV, and in those days you had to watch what was on the TV. You didn't get to choose what you wanted to watch from a list of every possible television show or movie ever made. You just had to watch what was on. And there was only a choice of 4 things. And this TV show came on, and it was called James Randi in Australia. And for those who don't know James Randi, he's a former musician come skeptic come mythbuster. So he goes around the world challenging, parascience or these people who pseudoscience, and challenging them to scientific tests. And he came to Australia, and those of you my age and older might remember it, but he was brought to Australia by a fellow called Dick Smith, who's also a scientist. And they did this documentary on TV, and you can get it on YouTube. You can watch it tonight when you go home. James Randi in Australia. And I watched it when I was I would have been about 18 or something, and I was completely fascinated by what they did. So they got these diviners from around Australia who were, came from a long family of diviners, and their parents were diviners, and they were very successful at finding water in people's properties. And they had, honed their craft, and they felt that it worked. And so he challenged them, and they raised some money. I think they raised about $10,000 or something, and they said, we will give you this money if you can show scientifically that what you do works. And they said, oh, great, it's like money for jam, this is easy. So they took them out to a back lot in Western Sydney, dug up the ground and laid 10 pipes in which they would put water, depending on where they opened the tap. So there was 10 pipes, and they covered them up with dirt, and they labelled them 1 to 10. And they said to the water diviners, okay, let's test the conditions first to make sure you're happy that it works. And so they started running water through pipe number 3 or whatever. And the water diviners walked across the pipes. And when they got to pipe number 3, their sticks went down, and they said, yeah, it's working. We're happy with the conditions. Everything's fine. We're going to be taking your money here. This is so easy. He said, okay, that's fine. And then he did a scientific experiment. And what they did is they would run water through one of the 10 pipes, but they didn't tell them which one. They got them to walk across and use their divining skills to say where the water was. So very elegant, very simple experiment. And of course, what they showed was that they were no better at guessing what pipe the water was in than chance alone. They guessed it in about 12% of the time. So it doesn't work at all. Water divining didn't work. It was just rubbish. And it was shown systematically and scientifically. And I remember seeing that at the time and thinking, wow, this is so cool. It's so simple. It makes so much sense to me. It's so rational and reasonable. And this is what the scientific method's all about. So I sort of fell in love with it. And even though I did surgery, I wanted to be a scientist. So I kind of study surgery. And we look at how effective surgery really is. And the results are surprising. And I kind of just remembered that in the back of my mind when I was writing the book on surgery, The Ultimate Placebo. And I went back and watched it again just for fun, because it was pretty cool. I hadn't seen it for a very long time. And it struck me in a completely different way. So I watched the experiment and I thought, yeah, okay, that's how I remember it. That was great. And then at the end, what really struck me was the reaction of the water diviners when they were shown the results of the study. Because that's the reaction of surgeons when they're shown that what they do doesn't work. And they just stood there and they said, no, that's your experiment is rubbish. And they're going, well, what do you mean? You were there, we did the experiment. And one of them said, no, I think there was maybe some metal particles in the dirt. And someone said, yeah, sunspot activity can sometimes play havoc with it, And they were making up excuses. And they said, well, why don't you believe it? He said, because we find water. Because it works. Because when someone gives me a call, I go to their property, I walk around, and when I tell them to dig, they find water. So your experiment is rubbish to me. But their thinking is not logical. Because if you look at the map of Australia and you want to see where you can dig to find water, it looks like this. Just about anywhere. They weren't looking at the other side of the equation. And so Dick Smith and James Randi said the true test of a water diviner, if they really know their skill, is to call them out to your property and ask them to tell you where to dig where you will not find water. And they wouldn't be able to do it. And it's this kind of thinking that they never got to. They were just finding water. That's it. And the reaction that they had was very similar. So now I'm going to take you on a bit of a Cook's tour of surgery, and it's a little bit chronological. So this is going back to 1939. Now, angina, chest pain from lack of blood supply to the heart, is very common, and it was even more common back in 1939. And surgeons thought of an idea to get more blood to the heart because it was a lack of oxygen to the heart that caused it. And so they had this great idea. There's lots of blood vessels that branch off before we get the branch that goes to your heart. And they said, let's take one of these other branches, which is called the internal mammary artery because it's sort of inside your chest, and it just goes to your ribs. It doesn't really do a whole lot. And they said, if we tie off that artery, then the blood won't go through it anymore. It'll go to the heart instead. So sort of more blood will go to the heart. And so they did it in some dogs, and they tied off the artery, and they found that blood didn't go through it anymore when they tied it off, and the blood instead went to the heart. So this made sense. So they started doing it on people, and the people said they felt better. So this became a common operation, a surgical procedure for angina in 1939, and it was widespread across the United States until somebody did an experiment in 1959, which was published in the New England Journal of Medicine. And what they did is they did a small experiment where they had a group of people where they made an incision here, found the artery and tied it off, and a comparative group of people, and this is the key to science, you've got to have the comparator, the opposite. And what they did is they made the incision, they put a little suture around the artery, and they didn't tie it. So the one group had placebo surgery, and they found that the results were exactly the same. It didn't do anything. And when you think about it mechanically, it was probably never going to do anything, but it just sounded like a good idea. And so much of what we do in medicine, it just sounds like a good idea, and it seems to work. And this is what we call observational evidence. So this is kind of like, yeah, I did it and the patient got better. So we assume that that means it works. So that's no longer done. Fast forward to the late 1990s, and Parkinson's disease is a very debilitating condition due to a lack of dopamine in the brain. So they had a great idea, which sounded good. They said, let's take some cells from an embryo, from the brain, the cells that produce dopamine, transplant them into people's brains, and then it will produce dopamine and cure their Parkinson's disease. And so they did this, and they had biopsies and everything to show that the cells they transplanted from the fetus survived and produced dopamine. That's all you need. It isn't all you need, because what you really need is evidence that it works, not evidence that the theory works. You have to have evidence that it actually works and makes people better. And unfortunately, this is where the evidence level stops for so many things in medicine and surgery, is they're going, there, we've shown in theory this should work. But nobody showed that it did. So they were doing this procedure until somebody did an experiment where they did burr holes. They made holes in the skull in all the patients, and in some of them they put in the fetal cells, and in some of them they didn't. They just pretended to. And nobody knew, the patients didn't know which group they were in. And what they found, that there was absolutely no difference whatsoever to the condition of the patient, whether you put the cells in or you didn't. It was completely rubbish. Let's go forward again. Migraine. More recently, doctors were doing a procedure where they put a wire in through the groin, in the artery, to the heart, to close off a hole in the heart. Now, a lot of us have a small hole in the heart. It's called a foramen ovale, and sometimes we're born with it. And if it's very small, it doesn't cause too many problems, but sometimes it can. And if it causes problems with the heart, these days, instead of having open heart surgery, you can just feed a wire up and put a patch on it and close up the hole. And they found that when they did this, people's migraines got better. So they did a theory and they said, aha, the migraines must be caused by something from the right side of the heart leaking to the left side of the heart, then going to the brain and causing migraines. We've found a cure for migraines. So they started doing it until they did an experiment. And when they did the experiment, they showed it was complete rubbish and made no difference whatsoever to the incidence of migraines. And when you think about it, it kind of never would, because the hole is always there and migraines are episodic. Migraines are focal. Anything that went through your heart would be general in your brain. It just didn't really make sense. You only have to think about things for a little bit longer than a few seconds, and then you realise that they actually don't make sense. But they still did it. Now, this is probably one of the most important ones. Again, another debilitating condition, but a very difficult condition to measure symptoms in because they fluctuate. You can have bad periods and good periods. It's not constant when you've got multiple sclerosis. So a surgeon in Italy whose wife had MS felt that he had found the cure for MS, and he said it was due to a congestion in the veins that drain blood from the brain, and material was being deposited in the cells in the brain, and this was causing it. And he found that the pressure in the veins was a little bit too high. So he developed a surgical procedure to open up the veins and drain them better and lower the pressure. And this was a procedure that he did for many, many years and claimed great success, and people got better. And people from all over the world, until very recently, were paying tens of thousands of dollars to fly to Italy to have this procedure done to treat their MS. And they said they felt better afterwards. Now, this is, of course, it ended up being rubbish, but what's important about this one is that the person who did the experiment was the surgeon himself. So he had the credit, I give him credit for doing the experiment. So he did the controlled experiment where he did it on some patients and didn't do it on other patients, and he found there was no difference. There was no benefit from his surgery at all, and he stopped doing it, and he said it doesn't work. And that's hard to do. One that I like to use is Emphysema, again, a very common, widespread condition, lung disease, not enough oxygen getting into your system. And a surgeon in America developed a procedure where he took out a part of the lung. Now, I have no idea how he rationalised that procedure, but somehow taking out part of the lung made the rest of the lung expand or something. You can make up a biologically plausible mechanism for anything you want. And to me, it just doesn't wash at all. And I go to scientific meetings and people say, yeah, but this is going to be great. You know, this is the future of medicine because biologically it's plausible that this would work. I say, I just don't care. It just means absolutely nothing to me to have a biologically plausible mechanism. Because nearly everything I've tested that has a biologically plausible mechanism doesn't work. It's not enough to have a biologically plausible mechanism. It has to actually work to help people. And so this guy, I don't know what the mechanism was, but he developed this procedure and it became widespread. It's called lung volume reduction surgery. It was done all over the world to treat emphysema. And people said they felt better afterwards. And not everyone was convinced. So Medicare in the US said, you know, we're not going to pay for this procedure because this is pretty expensive and it's a pretty dangerous procedure. I tell you what we're going to do, and this is a great model for the future. They said, we're going to pay for it. We're going to pay for this procedure, but only if you're doing it as part of a trial, comparing it to not doing it. Because then we'll know if it works, and if it does work, we'll continue to keep, you know, we'll be happy to keep paying for it. If it doesn't work, we can save ourselves a hell of a lot of money. So they proposed this trial, and the trial was drafted. But the surgeons backed up, and the surgeons said, no, this is no good. And the surgeon who developed the procedure wrote an editorial in the Journal of Cardiothoracic Surgery where he invoked the parachute analogy. Now, for those of you who don't know it, the parachute analogy is often invoked when people don't want to have a randomized trial done. They say you don't need a randomised trial to show that this procedure works because you don't need a randomised trial to show that parachutes work, right? You don't randomise people to wear a parachute and not wear a parachute and jump out of a plane. We just know that they work. So he invoked the parachute analogy. You've got to be careful about that because the study was published recently in which they looked up all of the times the parachute analogy has been invoked, and they found that most of the time what it was invoked for was later shown to be rubbish. Anyway, he did this. They did the study anyway, and of course they found no benefit to surgery compared to not operating. But the surgeons still didn't believe it, and they looked through the evidence and they just said, there is some differences. If you look at all the different time points, they followed patients up for 2 years, and they said if you look at the time points, the lung function after the first few months was on average better in the surgical group than the non-surgical group. And it sort of petered out over time. But that difference was due to the fact that many more patients in the surgical group died early. So the sicker ones died when they had surgery, and only the healthy ones survived the surgery. So it made surgery look better if you didn't count death as an important outcome. And finally, knee pain, which was mentioned by Sharon. So I think one of the bombshell articles was an article in New England Journal of Medicine in 2001, 2002 from the US, which was a sham surgery study on arthroscopy of the knee. So this is putting a camera and some instruments in the knee and giving it a washout for osteoarthritis. A very, very common procedure. In fact, the most common orthopaedic procedure in the world is a knee arthroscopy. I think they do something like 500,000 or 1 million per year in the US. So this is a very, very common procedure. And it showed that it was no better than placebo. People didn't believe it. They said, oh, that's rubbish. And I know it works. In my hands, the patients get better. And it didn't really change practice that much. And of course, the surgeons changed their story because they were doing it for osteoarthritis. And then this study came out and they said, well, we don't really do it for osteoarthritis. We do it for the torn meniscus, the torn cartilage. That's why we do it. But in 2013, a very high quality study came out from Finland comparing taking the meniscus out during an arthroscopy to pretending to take it out, doing a sham procedure, and found absolutely no difference. When I say absolutely no difference, if you look at both of these studies, there's actually a small advantage in the group that didn't have surgery, but that advantage was probably not significant. But it certainly wasn't helping people. And again, another surprise. And it prompted this cartoon in the Melbourne Age, which I think was pretty appropriate. And finally, we get to spine surgery, something that has not been subjected to a placebo trial. There's lots of different kinds of spine surgery, but probably one of the most controversial is a spine fusion. Many of you in the room may have had a spine fusion, particularly lumbar fusion. You can do fusions in the neck as well, but lumbar fusion for back pain is a very common procedure. So again, in America, I think it's around 350 to 400,000 spine fusions per year. The cost is about 100,000 per case. So start doing the math as to how many billions of dollars are spent on spine fusion. And in Australia, it's not much better. So it's a very common procedure, but there's not a whole lot of evidence to support it. The randomized trials that have been done have shown that it's no better than alternative therapies, and yet it's still commonly done. So that's an area that needs a lot of work. And injection therapy. Because it's so easy to do, we'll just give you an injection. We'll just give you a steroid injection, cortisone, prednisone, whatever. That this has become really an epidemic. And if you look at the graphs on steroid injections, say in the spine or in the joints, the graphs just go up and they just keep going up. There was a 7-fold increase in 10 years in the US in epidural steroid spine injections, and it's really increasing in Australia, and it's huge, but they don't work. They don't actually do anything. We wrote this piece in the Medical Journal of Australia a couple of years ago now, arguing the risks and costs, because in the UK they had called for a withdrawal of funding for these injections. We shouldn't be paying for it if they don't work, because we're paying for it. Doesn't matter if you're in a private fund or you're an Australian citizen or you're paying taxes or whatever, you're paying for it somehow. And in particular, this was timed, this was after contamination in the US, if you might remember, 2012, 2013, where some fungus was in 18,000 bottles of steroid, which was sent around the country and injected into people's spines. And 64 people died and over 700 were infected with fungus for a procedure that carries no benefit. Because when you look at the evidence and you look at the high quality evidence, the most scientific evidence, it shows no benefit. And yet we get articles like this. So this has only just come out, it's still to be published. And these are the kinds of studies that people read. So don't worry too much about the details there, but what this is a review of 2 different kinds of epidural steroid injections in the spine. One where you put it in the side and one where you put it in the middle. And the argument is, well, the people who believe you put it in the side thinks it works better, and the people who believe that you put it in the middle think it works better, and they're having this argument. So they did this big review, and this big review found that they were equally as effective. It didn't matter which way you gave it, they worked about the same. But it's articles like this that completely miss the point. These comparative effectiveness articles show you that if you give the injection from the side, it's just as good as if you give it in the middle. It doesn't tell you whether either of them work at all. So comparative effectiveness studies can equally be comparative ineffectiveness studies, because there's no control group that didn't get an injection. When you include them, you find that neither of them work. And yet these studies sort of miss the point to me. So, getting to the crux of it, how do we explain this perceived effectiveness? So I'm going to draw a bar for you, and this is the effectiveness, all right? From the bottom of the black bar to the top of the white bar, that's the amount of effectiveness that we perceive. This is how much we think we got better, okay? That's the perceived effectiveness. But the perceived effectiveness is made up of two things. It's made, that's the perceived effect. It's made up of two things. The specific effect of the drug or treatment or surgery or whatever it is, the intervention that you had, which may have some specific effect. And then what's on top of that is what we call the placebo effect. But it's this added effectiveness that is not related to the ingredient of what you had. Now, the partition between the black bar and the white bar can move up and down. So you can have procedures that have no specific therapeutic effect whatsoever, but have a very strong placebo effect. And you can have treatments that have a very strong specific effect, no placebo effect whatsoever. But either way, it's those two things that add up to what we perceive to be the effectiveness. And it's this perception problem that besets medicine. And it's a simple, logical fallacy that all humans are hardwired to fall for. So if you look at this, which people did in 1949, they looked at this chart and they said, wow, polio cases and ice cream sales map perfectly together. They are correlated. Now, human beings are hardwired to believe that correlation equals causation. That is a logical shortcut. It's not scientific, it's a shortcut. But we are not scientific, we take shortcuts. Evolutionarily, this is how we got here. If 100,000 years ago you went to a place for food and you ate some red berries and you felt sick afterwards, you would not eat the red berries again. It may have been the thing you ate before the red berries. It may have been something else you caught that made you sick. It may have nothing to do with the red berries, but you didn't conduct an experiment. You just didn't eat the red berries. That's a shortcut. That's assuming that correlation equals causation, and that's great. You can move on because there's plenty of purple berries and you can eat them. All right? If there's a big drought and the only thing left is red berries, maybe you'll try them again. But otherwise, you're not going to bother with them. The example I use in the book is my sister. I remember when I was very young, she's a couple of years older than me, we go to school together, we were in primary school. And she had a donut one day. She never had a donut. We weren't allowed to have all sweet foods and things like that. She had a donut and was sick afterwards, probably because the donut was off or something, I don't know. But she never ate a donut again. Now, she can eat cake. She can eat all the ingredients of a donut. She's not allergic to anything. But she can't eat donuts. And I said to her, why don't you eat donuts? Because they make me sick. So powerful is this inbuilt fallacy that we have. And so, of course, the common denominator here, does anyone know what the common factor or the confounder is in this association? It was summer. That's right. Both of them increase in summer. But you can think up biologically plausible mechanisms, and people did. The polio virus is in the ice cream. Ice cream makes your throat cold and lowers your resistance to the virus. I don't know. You can think up a whole bunch of things. It's easy to make biologically plausible mechanisms, and that's why I just don't bother with them. And this is the logical fallacy. In Latin, it's called post hoc ergo propter hoc. And in Latin, that means it follows, therefore it is because of. Okay? It's basically correlation equals causation. That's a fallacy. It's a very famous logical fallacy. And this is what happens with surgery, and in the example that Sharon gave us as well. But there's 3 reasons why we perceive improvement in surgery. One is the natural history of the disease. One is something called regression to the mean. And the other one is concomitant treatment. And they're the 3 things that we forget. They're the 3 things that we don't allow for. And we think it's all due to the placebo effect, and it's not really the placebo. It's really due to these things. There is a placebo effect, which I'll explain in a minute. So let's talk about these 3 things which trick us. So natural history is the first one. So this is a slide out of a recent sham-controlled surgical study on repairing a tendon in the shoulder or not repairing it, showing no difference between the groups. But everybody got better, because the natural history after you have a tear of this tendon in the shoulder is that you get better. So if you do an arthroscopy or a surgical procedure on them and they get better, you say you got better because of the operation, even though they were going to get better anyway. So there's a little bit of a urgency when you see patients like this that you have to operate on them quickly before they get better so that you can attribute their improvement to your surgery. That's natural history, but I've got a bit of time, so I'll tell the story of Archie Cochrane. So many of you have heard of the Cochrane collaboration, named after Archie Cochrane, who was a physician in the UK. He was actually a prisoner of war in World War II. And what he experienced there changed his way of thinking about the effectiveness of medicine. So he was put in charge of, not put in charge of, but he was the only medical person in a prisoner of war camp of some 10,000 prisoners under the Germans. And he had no medicine, except I think some aspirin. No medicine and no doctors. They wouldn't let them have a hospital. There were no doctors. I don't know what his status was at the time. And he complained bitterly to his German captors and said, you have to give us doctors. And the German captors said, Ärzte sind überflüssig, which means doctors are superfluous. And he thought, this is like a war crime. Like, I can't believe it, because he had people with dysentery, typhoid, open wounds, infections, and he thought, I'm going to lose thousands of men here are going to die. So in the 6 months that he was there, looking after some 10,000 soldiers, 4 died. Each one of them died from being shot while trying to escape. None of them died of the dysentery or the open wounds or the infections they had. And they got better. And he was completely floored by this. He said he couldn't believe that people got better without medicine. And he went back and questioned the way things are done and started this whole ball rolling. So, for instance, when he got back, the standard treatment after a heart attack was a week in bed. You had to lie in bed for a week after you had a heart attack, otherwise you'd drop dead. You know, that was the thinking at the time. And he said, well, what's the evidence for that? And they go, it just makes sense. And he said, well, I'm going to challenge that. So he did a study where in one group they laid in bed for a week, in the other group they just got up and went home. And he found that the group that got up and went home survived better. So they were actually harming people by leaving them in bed for a week. And yet it was just made sense. So that's natural history. Regression to the mean is harder to explain. This is a chart out of the 2013 arthroscopy study from Finland showing the sham group and the arthroscopy group improving by exactly the same amount. Regression to the mean is a little bit hard to explain because it's a statistical term, but people will go back to the average. And if you get people who are particularly bad at the time in a fluctuating condition, they will regress to the mean. So, for example, if you had some patients and you were, considering whether they needed a knee arthroscopy and they had arthritis in their knee, arthritis is a fluctuant condition. If you've got arthritis in your knee, it's not exactly the same every day. You'll have a bad week, a good month, a bad day, a good year. It's all over the place, and sometimes it can be really bad. Like I remember, last May or whatever. Gee, for a whole month there, my knee was terrible, but it's back to what it usually is now. So if you take the patients that are really bad, like if a patient comes to me and says, yeah, I've had arthritis for a few years, but lately, it's really bad. I can hardly walk on it. You've got to do something. You do anything to that patient, and they will regress to the mean. They'll go back to their average. You got them on a chart like this. Okay, you do anything to them when they're up here, afterwards they're going to be better. That's regression to the mean, and that tricks us as well. And the other one is concomitant treatment. Again, don't worry about the technicality of it, but this is a reasonably famous study in the orthopaedic world because there's a material, a genetically developed material, which is a copy of a protein that is inside every person, called bone morphogenic protein. So it's a protein that makes bone. Like, that's pretty cool, right? So they developed this. It took them decades to develop this drug. And when they injected into rats, bone formed around where they injected it. So they've got the cure to bone healing, right? Because it makes sense and because it works in rats. Again, it's rubbish. It doesn't mean anything to me. Most animal experiments don't translate to humans, and they're largely a waste of time. So you've got to prove that it works. So they said, okay, we're going to do this study. And on this study that they did, on the basis of this study, the drug was approved by the FDA and made billions of dollars worldwide since. And yet it doesn't work. And in fact, it's no longer used largely. I haven't used it for about 10 years. And most surgeons don't use it anymore. But for a while, it was huge on the back of this study. So what did they do with this study to show that it was so effective? Well, they had people with a broken tibia, so the lower leg, tibia fractures that hadn't healed. So it's what we call a non-union. So they had a break, but the bones hadn't knitted together. So normally you've got to do something. So what they did is that each of the patients had their plates or nails or whatever it is taken out. They had the core of the bone reamed out, which is what we normally do, and had a new nail put in the centre of the bone. And that's actually common, standard orthopaedic surgery. It's the kind of stuff I do all the time. And then they had one of two things injected into the gap. One was this BMP material, this new material, and the other one was a bone graft where they took some bone from the hip and injected it in there, which is really kind of like commonly done. Again, that's the standard. And they found that the bone graft worked a little better, but only a little better. I think it was like 85% got better instead of 78% with the BMP. And they felt that was pretty equivalent, and they said this is just as good as bone graft. You don't need a bone graft anymore, you just need to use this drug. And by the way, it's $6,000 a pop. So they sold that drug based on that. Now, when people went back and looked at this trial, they said, well, hang on a minute. Everybody in this trial, apart from having this injection or this injection, also had their bone reamed out and had a new nail put in. Yeah, that's right. Both groups had exactly the same, reaming out, the nail put in. And they said, yeah, but if you only ream out the bone and put a nail in and don't do anything else, the chance of healing the bone is 85%. So the concomitant treatment here is that if you had another group of patients and not given them any injection, done nothing to them except the reaming and the nailing, you would have got exactly the same results. So it was no better than doing nothing, but they didn't compare it to doing nothing. They didn't have a placebo. This was a comparative ineffectiveness study. So enough of the technical stuff. So there's two ways we can perceive the improvement. Sometimes the patient perceives the improvement. They think, yeah, I feel better. And sometimes the doctor perceives the improvement. And this is a problem because the doctor perceives it and the patient doesn't. That doesn't help the patient. So we're going to talk about that a little bit. And there's a lot of problems out there. This is a famous paper you might want to look up with what's wrong with a lot of the science we do. And there is a lot wrong with it. And we actually published on this looking at the difference between surgeon satisfaction and patient satisfaction. So for instance, in the bottom one, we had patients with tibia fractures, just like I was describing. And we said to the surgeons of the patients, we said, how do you think it went? This is like 6 months later. Are you satisfied? Do you think the patient had a good result? And 2/3 of the time, about 67% of the surgeons said, yeah, that was a good result. Everything went well. When we asked those patients, the exact patients that we were asking the surgeons about, the success rate was about 44%. So the difference was 67% to 44%. Joint replacement's the same thing. If you're sitting at a dinner party next to an orthopaedic surgeon in the near future, ask them about knee replacements. Say, what are knee replacements like? How do they go? And they'll say, oh, they're fantastic. 95% of them do really well, 97%, it's a great operation. And then when you're at another dinner party sitting next to a physiotherapist, ask them about total knee replacements. They'll say, oh, they're terrible. The patients whinge and complain, they hate it. So we asked the patients and we asked the surgeons. And again, we found this discordance between how the surgeons think the operation went and how the patient thinks it went. And this is a problem because the decision making when it comes to having a knee replacement, whether or not the surgeon recommends the procedure is based on the surgeon's perception of how good the operation is. And their perception is wrong. This was done by some researchers at Bond University on the Gold Coast. And they looked at all of the papers looking at clinicians' expectations of benefits compared to patients' expectations. They found surgeons, not just surgeons, doctors, consistently overestimate the benefits of what they do and, importantly, underestimate the harms. And this is a problem. So why do people feel better when maybe nothing happened to them? And that's because they have to pass through a therapeutic envelope. And this goes for any intervention. Doesn't matter what it is. It doesn't have to be medicine. But to go from being a person with a predicament or a complaint to a treated patient, they have to go through a lot of things. They've got to go through this therapeutic environment. They may have concomitant treatments. There's factors to do with the intervention. There's a lot of factors to do with the therapist. I don't have to tell you this. It's how you relate to the patient, which makes a huge difference to the effectiveness. There's social factors, there's the natural course of the disease and regression to the mean. And there's been a lot of research done about placebos where they've looked at like the colour of the pill and the effect that the placebo, nothing in it, has depends on the colour of the pill. And of course the size of the pill. Bigger pills have a stronger placebo effect. More pills as well. And the cost of the pills, there's a great experiment where they gave patients all the same placebo. There's nothing in it, same drug, identical drug, 2 groups of patients. But they let them overhear a conversation in the corridor about how much the drug cost. And in one group, the people in the corridor were commenting about how cheap the drug was and how it only cost like a few cents. And in the other one, the doctors were in the corridor were sort of commenting on how expensive that drug was. And the ones who thought they had an expensive drug got better more than the other ones. And of course, 2 pills is better than 1. And active placebos are interesting. So these are placebo like a pill. It still doesn't do anything to your system, but it might have something in it that, say, makes your tongue tingle, So it makes people think, oh, I got the real one, and they're more likely to get better. But beyond pills, we know that injections have a much stronger placebo effect than pills. And the more painful, the more it's a procedure, the more elaborate it is, rather than just sort of taking a pill, see you later, the stronger the placebo effect. Devices help, and if you make it look scientific, it helps. If you wear a white coat, it helps. And if the whole thing is delivered by a confident, enthusiastic, authoritative, qualified provider, someone like a surgeon who's always think they're very authoritative and they're always very certain that you're going to get better. And that's what they say about surgeons. They're often wrong, but they're never in doubt. And really you get, the surgery being this sort of ultimate placebo. It ticks all the boxes. Now this has been reviewed. This was published in the BMJ only a few years ago from Oxford, and they looked at all of the studies that have ever been done comparing a procedure to a placebo. And they found in just over half of them, the placebo was just as good as the intervention. And in all of the recent surgical trials comparing surgery to placebo, all of them have shown that the surgery is no better than placebo. Every single one. And people complain, they go, oh, we shouldn't be doing these studies. Why not? Surely we should be doing more of them, As they say, oh, they're unethical, but I'll get to that in a minute. And we did this review where we said, well, how many of the procedures that we do on a day-to-day basis have been subjected to not a placebo trial, but just any comparative trial, a randomized trial comparing them to not doing the procedure. And so we looked up in 3 hospitals in southwest Sydney, nearly 10,000 procedures done over a 3-year period. We grouped them all and we said, how many of these 10,000 procedures have been subjected to a trial comparing them to not doing it, to non-operative treatment? And we found it was about half. About half of the stuff we do have been subjected to such trials. Now that's not unusual, and that figure is about average across medicine. So it's not bad for orthopaedics, it's not good. It's about half. So we've got a long way to go to get the evidence to support what we do. The surprising finding of this was that in the studies that had compared surgery to not doing surgery, those half of all procedures that we do, in half of them there was evidence that the procedure was no better than not doing it. And yet we were still doing it. So why do we still operate? We've got all this evidence that stuff doesn't work, but we're still doing it. Is it because we believe it to be effective? Is it because of patient demand? I get this all the time. They say, well, the patient wanted an arthroscopy. I'm like, really? I don't find that at all. I still see patients and I see them with their knee MRI and they come in and they say, oh, I think I need an arthroscopy. And I go, well, no, you don't, because if we do an arthroscopy, the results would be no better than if we pretended to do the arthroscopy, and you're likely to get better anyway. It doesn't work. And then the patient says, well, then I don't want an arthroscopy because I'm not an idiot. It's not, you just have to explain it to them. I don't buy this patient demand thing. And the other, again, these things sound good until you think about them for more than a second. And quite often surgeons will say, no, I don't like to do an arthroscopy on knees unless they've failed non-operative treatment. Because if they've failed non-operative treatment, then clearly you've got to operate. When you think about it for a second, you go, yeah, well, they've failed non-operative treatment, so we have to give operative treatment. Yeah, that makes sense. Think about it. You've got an operation, knee arthroscopy, that doesn't work. Okay, it just doesn't work. Right. Now, does the failure of any other treatment suddenly make it work? It still doesn't work. Again, it just kind of sounds good. Lack of alternatives. That's the other thing surgeons say. They say, well, if you don't want us to do a knee arthroscopy, we're going to have to do a knee replacement. That's the only other alternative. And you go, no, you haven't considered the alternative of not doing an operation. They often don't think of that. And the other response, this is most concerning, is I had dinner with an orthopaedic surgeon, and soon after this study came out in late 2013, would have been 2014, and he said, this study of sham arthroscopy is great. I'm doing more arthroscopies than ever. And I said, okay, you've got my attention. Why are you doing more? And you saw the charts yourself. Most of the patients got better. He said 2/3 of the patients got better. I don't care if it's placebo, not, I don't know any of that rubbish, but if 2/3 of the patients are getting better, I'm going to keep doing the procedure. So what he's saying is that he's using the placebo effect. There's obvious problems with that, which I can elaborate on if you like. But largely, it's this. Surgeons are still doing the procedure because they're finding water. You get it? The patients are getting better. And they're saying it follows, therefore it is because of. That's the fallacy they're falling into, and they don't get it. And the criticism I get of evidence-based medicine is basically this. People say physicians are not prepared to discard therapies validated, in quotation marks, by both tradition and their own experience on account of someone else's numbers. In other words, I was taught that this procedure works. I can see in my experience that patients get better, and therefore I will not be influenced by the numbers from some study that was done on the other side of the world. That's the basic criticism, and this is not new. This is a direct quote from the American Journal of Medical Sciences from 1836. Does anyone know what this was written in response to? It was written in response to a landmark paper way back in the early 1800s where they looked at bloodletting, bleeding, using leeches for pneumonia, because that was the standard treatment for 2,000 years. Because it worked, because patients got better. So they looked at this and they said, well, there's lots of different ways of bleeding people, right? And sometimes you can bleed them early or bleed them late or bleed them a lot or bleed them a little bit many times. And so they looked at the timing of when you did the bleeding and how much you did, and they kind of looked at it statistically and looked at the results. And they said, yeah, there's a trend here. It looks like the later you do it and the less you do, the better the results. And they didn't believe that. So surgery historically relies on biologically plausible mechanisms, some kind of lab evidence, which is, again, means nothing to me. Just because those fetal cells survived in the brain, it doesn't mean anything unless there's actually evidence that it works. And observational studies, but what should be used is the method with the least error. And the method with the least error is a scientific experiment, because science isn't anything fancy. Science is just a method of error reduction. It's the least wrong way of looking at something. It's just a systematic way to reduce error. There's nothing magical about it. And it's got lots of problems. I paraphrase Winston Churchill when I say science is the worst way of trying to study something, except all the others. So it's the least bad way we have. We reduce all kinds of error by studying things scientifically, like Dick Smith and James Randi did. So we need randomized trials with low risk of bias. And this is what happens if you don't do it. So these are two studies, graphs taken out from two studies on knee arthroscopy. The study on the left is the worst study done, the lowest quality study. It's hard to tell whether they even randomised people. It wasn't done well. The patients weren't blinded. The observers weren't blinded. Scientifically, it was very low quality. And they showed that arthroscopy basically saved their lives. The results were so dramatic that everybody got up and danced as soon as they had the arthroscopy, and the people that didn't have it were miserable and died. It was just so strong, this effect. And this was the study from 2013. Now, this has been rated by others externally as possibly the highest quality, scientifically, the highest quality study done in orthopaedics. And I've since met the guys that did this study. They did this study so well. So not only were the patients blinded, they didn't know what they got. The people that were assessing them afterwards didn't know what treatment they got. It was all kept hidden, blinded until the end. And even the statisticians that did the statistics on this study didn't know. They were just labelled A and B. They didn't know which one was which, so they couldn't sort of massage the statistics. And then once they had the results of the study, instead of unblinding themselves and writing the manuscript to send to the journal, the authors wrote 2 manuscripts. One if group A was placebo, and the other manuscript if group B was placebo. And then they signed a document saying that they would stand by those manuscripts and not alter them once they were unblinded. And then everybody was unblinded after they'd written the paper. This is a very high quality scientific paper. And that's the difference you get. So this is why we need blinded randomised trials, to overcome all of these things. You just wipe out all these effects once you have a good control group, something to compare it to. It overcomes this perceived effectiveness, overcomes the surgeon's biases. Now, a little bit on the ethics, because I actually don't get this as much as I used to, but when I used to give talks like this years ago, people would say, oh, you can't do a placebo surgical trial. And I went, oh, can't you? That's a shame, why not? And they'd say, oh, because they're unethical. And then we go, oh yeah, they're unethical. I forgot about that. And it's kind of like, one of these things like, oh yeah, oh, it sounds kind of right, kind of rings true, doesn't it? Until you think about it, all right? There's a confusion between the ethics of clinical practice, where we're not allowed to expose people to potential risks without a potential benefit. But the ethics of research are completely different. That's to find the answer in the least biased way possible. And when you think about it, we subject people in experiments to harm all the time. Electric shocks, chemotherapy. We do that all the time. Why not a few holes in the skin? It's probably safer than some of the chemotherapy drugs that we're subjecting them to. And the other thing is so this is, the difference is that we talk about individual patients when we're talking about patient care, but we're talking about the risks and benefits to society when we're talking about research. But here's a little mind experiment. I've published on this double standards. In fact, this is true today, and it's been true for a long time. If I want to do a new kind of hip replacement, okay, I want to do a hip replacement from the inside or upside down or something, or I want to put the prosthesis in upside down, I don't know. I just got some kind of new way of doing a hip replacement. I can do that tomorrow, and I'll just start doing it. That's fine. I don't need ethics approval to introduce a new procedure. Nope. And people do it all the time. Okay, so that's done. So now I've done maybe 20 cases, 30 cases, and now I want to find out how they're going, right? I want to report it. I'm going to ring up the patients and say, how you're going. I'm going to compare to the patients that I did before who didn't have this new approach, and I want to do some kind of science to work out whether this is a good thing or not. Okay? I can't do that until I get ethics approval. It's the complete opposite. You should have to evaluate new things, and you should have to apply for an ethical exemption to not do it. It's the complete opposite that we have at the moment. And this is the mind experiment that I wanted to go through with you. So this is, and we can call this like a new back fusion procedure or back fusion, if you like. So we've developed this, it's plausible, kind of makes sense, I think people get better, let's start doing it. And the procedures perform widely, so for back fusions there's millions are done every year around the world, right? Because we think it works. We don't know, we don't have good evidence at all that it works. So that's the current situation, right? And people say that doing a placebo trial is unethical. Well, this is what we're doing now. Now compare that to the ethics of a placebo trial. Here we would need 1 to 200 patients. We would expose half of them to give them the normal procedure that every million of people in the world are getting every year. And the other half we'd pretend to do it. They'd get a placebo, right? Now in that review of placebo surgical trials that I mentioned from the BMJ before, it should be noted that the harms, when you compare the two groups, are less in the placebo group. And when you think about it, it kind of makes sense, okay? Because they're having less done to them. So the risks to the patient are higher in the real operation than in the placebo. So you've taken 100 or 200 patients, you've done a high quality experiment, and you've found out whether this works or not, potentially saving 1 million patients every year from having the procedure. So what's the ethics of doing that compared to the ethics of what we're doing now? Doesn't look so unethical to do the procedure now, does it? And I'll wrap it up soon. So we need to treat surgical procedures like drugs. We need to only pay for new treatments if it's part of a trial, like they did for that emphysema trial. And it's a win-win. It reduces the uncertainty. We find out if the damn thing works or not. And then if it does, great, everybody wins. It gets funded and people get better. If it doesn't work, we save ourselves a whole lot of time, effort and harm, as well as cost. And there's lots of placebo surgery studies being done now. There's been studies completed in the shoulder, in the knee, tennis elbow, doesn't work. None of them work. We're doing one now on lumbar spine stenosis, and we're writing up one for rotator cuff repairs, one of the most common shoulder procedures. We need one for spine fusion. So in summary, the perceived effectiveness of surgery is greater than the true effectiveness. We've shown this over and over. Surgeons tend to overestimate the benefit and underestimate the harms. Blinded trials offer the least biased, the least wrong way of determining effectiveness. But most surgical procedures have not been subjected to these kinds of trials. And that's where we are today. Thanks.
Thank you, Ian. That was a fantastic mini science lesson for us here today. It's brilliant. And I might actually just invite you back up to comment on a fairly crackingly good question we had from our webcast audience while you were talking. As massage therapists, how do we ethically broach with our clients issues around ineffective medical practices? So, for example, if we've got someone who comes and says, I need to have a knee arthroscopy, how would we have that conversation?
So this is a common question, is what do I do as a patient? Or, what do I advise your patients or family members or anyone who's got this problem is facing it? So there's a couple of things, and there's actually some advice. If you go on websites, there's things like 10 questions you should ask your doctor and that kind of stuff. But a couple of things I always recommend is get a second opinion or get a third opinion. And one thing I'll tell you is that surgeons don't mind. Doctors don't. We really don't mind. People get second opinions all the time. We love it. It's great. It's no problem at all. Because it makes you more confident with your decision, makes you happier with your decision. So get a second opinion. Sometimes the second opinion is the same, maybe get a third. But the other thing is to ask these specific questions. So when you want to give advice to a patient who's considering a surgical procedure, the thing you have to ask, and it sounds kind of like third grade stuff, but nobody asks it. And surgeons don't ask it themselves. And the question is, what is the difference to me if I have this procedure compared to if I don't have it? People don't ask that. Just say, what is the difference? What evidence do you have that I will benefit, and by how much? And what is the risk to me to get that benefit? And people don't ask it. And if I can just tell one other little anecdote, and it's a personal one. My father was diagnosed with prostate cancer, and it's common, and he was older. And but it's a woolly diagnosis because sort of by the time you get to a certain age, kind of nearly everyone has it if you look for it hard enough. So they did lots of biopsies, and in some of the biopsies they did, it showed some cancer of a kind of a not real bad but not benign, in between. So it's got cancer. Probably would have been better off not knowing, but it's too late now because he had the PSA test. The PSA test was positive. Then he had the biopsy, and 1 or 2 of the biopsies were suspicious, and then he had more biopsies, and then finally decided, you've got cancer. So I sat with him while he sat through a 30-minute consultation with a surgeon and a 30-minute consultation with a radiotherapist. And I sat quietly, and these guys knew me and they knew about me, and I didn't say anything until the end. And I was very quiet, and these guys were good. They showed graphs, they did everything, and they explained the treatment that they were offering, these 2 alternative treatments. And I asked the same question at the end. I said, what's the evidence that survival is better if you have this operation than if he doesn't have this operation? Because clearly there's high risks with this operation, high risks of incontinence and impotence and things like this. A really big procedure to have. So I said, what evidence do you have that the survival is better with the operation compared to not having the operation? I mean, a really simple question. And the surgeon went off and he's going, oh, you're talking about that study from New York where they... Yeah. And I'm going, I'm not talking about anything. I haven't even looked it up, And I honestly didn't know. I figured he'd know. I'm not a urologist. And in the end, both of these specialists were saying, well, we don't have any evidence that the survival is going to be better in his case. And I said, well, why are we sitting through this? Why are you suggesting we have treatment? And they said, oh, you've got to have treatment. And I said, why? And they said, because he's got cancer. He won't sleep at night unless he knows that it's out. I'm like, well, why did you tell him it was in there in the first place? And yet this is it. They said, oh no, you'll have to have it out. And I said, well, I don't think that's worth the risk. So in the end, he decided, it's his decision. I couldn't be, too persuasive or anything. I didn't want to be. And he decided that he would go for what they call watchful waiting, where they don't operate and they just, do another test in 3-6 months or something like that. I think that's the right thing to do. So he did that, and he was happy. He had no problems at all. Everything was fine. And he went back for a test about 6 months later, and the test was still the same, and he still got cancer, and he had the operation. Incontinence since he's never been the same. And I said to him, why did you have the operation? He said, I couldn't sleep at night knowing I had cancer. So it's just sort of a good little snapshot of what's wrong with the system.